Hello, everyone. My name is Radosław Nawrzycki. I am a second-year internal medicine resident here at CU, and today I'm excited to be talking to you about VEXAS, also known as venous access ultrasound, what we have done in the past and where we are headed in the future. But before that, let me give you some background. So over the last 6 months, we've had about 80,000 admissions at UC Health, and nearly 80% of those patients have undergone active volume management with either intravenous diuresis or volume resuscitation with things like crystalloid. With this practice being so common, I think it's imperative to have accurate volume status assessment. However, it can be difficult. For example, the physical exam is quite limited. Limiting factors include things like patient anatomy or variable techniques. You may say, let me look at the inferior vena cava. The IVC ultrasound also has its limitations, namely things like patient comorbidities or athleticism status. Inaccurate volume status assessments can lead to things like iatrogenic AKI due to overdiuresis or conversely volume overload. Here we propose VEXAS as a solution. While yes, we do look at the inferior vena cava, we also look at other things such as pulse wave Doppler waveforms across the hepatic, portal, and renal veins. And as you can see here, it's quite time effective, accurate, and it's inexpensive. Here's just a figure demonstrating the superiority of venous access ultrasound over IVC diameter alone, in particular in patients who are congested by right atrial pressure on right heart cath. Speaking of right heart cath, this is exactly where we were last year, just one publication validating VEXAS against objective measurement using right heart cath. And since then, we have had a total of 5 publications and submissions to high impact journals and 10 abstracts accepted to nationwide conferences, examining things like tricuspid regurgitation, diuresis in congestive heart failure, or now moving into sepsis. More on that later. This is all thanks to our team of 22 researchers, and we are still growing. Our vision in the long term is, again, to limit the iatrogenesis, improve patient outcomes, shorten hospital length of stay, and also reduce readmission rates. Before we get there, we have some work to do. Sharks, this is where you come in. We ask for your help with ongoing validation of VEXAS, refining our technique, and expanding our population. Namely, we ask for help as we move into the phase of examining acutely decompensated heart failure and VEXAS, as well as sepsis and VEXAS. We also ask for your help with study design, data management, and statistical analysis. Hopefully, once we have completed our observational studies in decompensated heart failure and sepsis, we can build enough grounds for VEXAS to become a universal echocardiographic standard of volume assessment. Thank you so much for your time. I would like to open it up for any questions.
Hi, my name's CJ Mowry, and I'm the representative from our team to share our project on integrating a Spanish language interpreter onto internal medicine teaching rounds. All right, now I want you to take a moment to reflect on recent experiences with virtual interpreter services. What were some of the struggles? Can you recall an experience where you had to wait minutes for an available interpreter? What about losing connection or having such a poor connection that the translation is coming through unintelligible? Or perhaps you're using a phone with poor audio and your patient is unable to hear the translation. And lastly, consider if the interpreter felt like a part of the team or just a service. And is that ideal? The data suggests that this is not ideal. Here we show a sample of Pragmatic survey data, which is sent to all patients discharged from Denver Health. We see Spanish-speaking patients discharged from internal medicine floors in blue and Spanish-speaking patients in orange. When we look at the transitions of care metrics, specifically the patient's understanding of their medical condition and why they're taking the medications they're discharged with, we see that Spanish-speaking patients have a dramatically lower understanding. Could this be a result of our current communication model? At Denver Health, roughly 25 to 30% of patients admitted to internal medicine are Spanish speaking. So the opportunity for improvement is huge. Consider the impact of a QI project that targets nearly 1/3 of patients admitted to your hospital. For our implementation, we propose to integrate a Spanish language interpreter onto teaching team rounds. And so instead of having a virtual interpreter on the phone as we're in the room with the patient, we'll replace that with an in-person interpreter that is a part of the team for the specific patients that we're going to see. This interpreter could start with a team such as Long's, which is one of our internal medicine teaching teams, and then move on to Blanca and then on to Pikes after a set period of time. This way, each team has the opportunity to work with the Spanish language interpreter and utilize them efficiently to see their Spanish-speaking patients. Our project has several aims, although the primary aim is to improve the education of Spanish-speaking patients, which can be measured using metrics such as the Pragmatic survey. We hope to increase these metrics by at least 10% within 3 months of implementation. Second, we want to demonstrate an improvement in provider and interpreter satisfaction, and we hope that by fostering a collaborative environment, we can improve the connection between these two groups. Lastly, we want to monitor costs as we go through this project and demonstrate cost neutrality, which we believe is feasible given the high cost of virtual interpreter services. So far, we've demonstrated that there's a need to improve communication with patients with low English proficiency. We have a group that's strongly motivated to make change, and we've garnered widespread stakeholder engagement, including among residents, hospitalists at Denver Health, and the Language Services Department at Denver Health. We believe the last piece of the puzzle is to bring you in, the Sharks. Our need from the Sharks is twofold. First, our project would benefit from expert QI coaching to guide our implementation. And second, data acquisition guidance and analytic support would improve assessment of our intervention to maximize data output and inform future modifications to improve our communication processes. Together, we can reduce inequities, improve the quality and safety of care provided to our patients with low English proficiency, and improve the patient and provider experience in our hospitals. This is our whole team. I hope you'll strongly consider joining us.
Currently, the cost to employ an in-person interpreter is about $50 per hour, which is what we are proposing, versus using currently the language line solutions is around a little bit less than $1 per minute, and then versus the iPad or the video interpreters are a little bit less than $2 per minute. So they're roughly equivalent based on how often the in-person interpreters are actually utilized, which at this point, based on discussions with Maria, the current system of in-person interpreters is overall poorly utilized in terms of provider knowledge about their services and current status. Yeah.
And additionally, the Spanish interpreters that are present at Denver Health are salaried employees, and so they aren't necessarily getting that exact per hour rate. And since they're there already and being underutilized, it wouldn't be raising the costs.
Speak to why they're currently underutilized?
I think just speaking from my own experience, it's oftentimes much easier to just call the phone number when you're in the room speaking with the patient, versus having to coordinate a time with the team to kind of get that set up, which I think is part of the benefit of our approach. I know it was a little bit hard to hear, but our idea is essentially having structured time with an in-person interpreter. And so you've got the whole team there, and you can be having those conversations, doing daily education. That's really integrated into rounds already instead of having to find separate time.
And I'll just add, I think going on that, it's the efficiency as well, where they're housed in another building. So they're having to walk across campus to go to the hospital for one call and then back, and they're kind of going back and forth. And so with our model, we're proposing they actually kind of stay on the medicine wards for that period of time to kind of efficiently utilize their services.
Right. And what are they doing in, oh, go ahead. You had another.
Oh, I was just going to add, speaking on efficiency, just based on my own personal experience, using a phone interpreter, you have a call drop, you have a lag. I think it ends up taking a lot more time using the phone interpreters compared to having somebody there in person. You just don't have those technical difficulties. So I think cost-wise, it might be more efficient.
And I know one of the hopes with the Shark Tank winnings would be to have data collected. Do you know specifically where the data exists for how much we're paying phone interpretation versus in person? Do you know where that data actually lives?
Yeah, I believe currently we are, the Denver Health Language Services is working on a dashboard to collect all the data currently. And it's in the, I believe, the preliminary stages of collection.
Yeah, and that dashboard's mostly for Epic related data, but we're working, part of our team is actually the language services department at Denver Health that are very invested. And so we actually created like a code so that every time our internal medicine residents call a virtual interpreter, they're inputting a code that is specific to internal medicine. So we can draw the data from that to see exactly how much our residents are utilizing that service.
All right,
Great.
that is the amount of time we have. Thank you so much.
Thank you.
Come on, clicker. All right, we'll do it manually. Maybe. That's why. We're good now. No. Doesn't go. Mhm. It's on annotate mode, so now it's just making red dots. It's blood, actually blood in the water. There we go. All right. Number 3, Dr. Perreault talking about PATHWEIGH.
Hi, I'm Leigh Perreault, and this is PATHWEIGH, Pragmatic Weight Management and Primary Care. It all started with a question, and maybe you've had this question too. Why do we routinely manage obesity-related diseases when we could cure them with weight loss? Turns out there's a lot of reasons for this, and they exist on the side of the provider and for the patient. At the end of the day, it's really sort of a learned helplessness on both sides. I practice in a family medicine clinic as the only endocrinologist in Westminster, Colorado, and I wasn't the only one feeling like I had this question. 2 of my colleagues and I came together and asked our local Epic person to create some simple tools so we could track patients in whom we were prioritizing their weight over their weight-related complications. After doing this for 18 months, it turned out that our patients were getting 3 times more weight loss than our control clinic. This was great news for us, and we took it to the UC Health leadership that voted to take the care process across our healthcare system for primary care. The NIH funded us to study if and how it works. Epic continued to refine our tools and even build new ones, while the Compass Data Warehouse extracted data on the back end. Collectively, we call this PATHWEIGH. If you remember nothing else I say today, just remember this. Pathway, it's not a weight loss program. It is a process of care so that patients can receive weight management services in a routine medical setting and providers know how to provide it. There are 4 specific steps and they involve everybody from alerting patients to letting the schedulers know, the medical assistants, and really educating providers around best practices on obesity management and also making that visit extremely smooth and time efficient. There are operational components of Pathway that exist in the background, and they are in the areas of tool, training, and support. And you can see our website is listed at the bottom of this slide. So we have indeed successfully deployed Pathway across all 66 primary care clinics of UC Health that collectively impanel 1 million patients, and we have 76,000 patients enrolled in our clinical trial. It has never been done anywhere in the world, and all eyes are on us here in Colorado. So here is our ask for the Shark Tank competition. We are asking for data prioritization, specifically expanded data from Health Data Compass in the area of claims data, so we can look at our cost effectiveness, analytics development, using the data that we're collecting to develop real-time decision care pathway for patients that live in Epic and can be used by providers. The visibility for sure will help us with our preparation for dissemination outside UC Health. But we don't want to just ask for something, we want to give you something back too. If we win the Shark Tank competition, then the Department of Medicine shares in the legacy. Our success is your success. And it really is all about helping patients, which is what this project's about. Further, the CU Office of Innovation would thank you as we march towards commercialization.
I appreciate the confidence of Dr. Perreault, who's already standing by the trophy and almost raising it up, but not quite yet, Dr. Perreault. Sharks?
All right. Well, thank you very much for that excellent presentation. I wanted to ask you a little bit about what you think sets this program apart from other traditional weight loss programs that include things like counseling. And then can you talk to us a little bit about the sustainability of both the program as well as potentially some weight loss that is achieved because of this program?
Awesome questions. The first one, everyone in this room should know the answer to. It's because it's not a weight loss program. It's not a program. It's a care process. So if you think about what is available for patients right now for weight, just take some of the newer medications, for example. Many of our patients don't have access to them because insurance doesn't cover them. Providers don't know how to prescribe them. So they're almost like these beautiful, fancy cars that sit in a parking lot. So Pathway is effectively the infrastructure, the road that those cars will run on. So you could put a weight loss program on Pathway, and that could be an option for a provider to send a patient to that during their visit. You could put anything on it, and referrals and procedures and anything else, that all the things that are to come in the future, you could put into Pathway, but it is not a weight loss program. Weight loss programs are fee for service, they're standardized, people supposedly graduate. None of those things are true. This is weight management delivered by primary care. So it's very different. It is not like any weight loss program because it's not a program. The second question around sustainability. So our tools have been successfully deployed to all 66 UC Health primary care clinics. It lives in those clinics now. So the tools have been built by Epic, deployed into those clinics in our healthcare system. They're only available right now to primary care per the study design from the NIH. Could they become available to specialists, pediatrics, other folks? Absolutely. And lots of people have come asking. We haven't done that yet because we don't want to contaminate our data collection, but it is absolutely possible. So we've also built enduring material to onboard new providers and staff that also lives along this in Epic.
Fantastic. And a lot of work has already gone into this program, clearly based on
Not a program.
I'm curious just how much additional support would be needed in terms of Epic around the Epic build for the implementation of the project through Shark Tank.
Yeah, absolutely. So it's all really about reducing the numbers of clicks. I mean, we all see patients, right? We all want less clicks. Anybody disagreeing here? So anything that we can do to help our providers provide care for patients around their weight that makes it easier and faster. Because as many of you may know, primary care, they're dealing with 14 different things in 15 minutes. We have to make this easy. So anything that we can do to improve the interface to just make it flow easier and better is something that'll just increase the uptake. And as I tell my team all the time, our threshold is to make Pathway easier to do than to not do, because that's how busy primary care is.
And with the last 45 seconds, I'll just ask a little bit about the educational services that would be provided for providers for implementation of Pathway.
Yep. So we have a 2-hour e-learning module that's eligible for CME credit. And we also have purchases licenses through the World Obesity Federation that we give out to providers who request additional training. That's 8 hours of additional training. Also, they get CME credit. So we're in the process of developing a course with the people in Epic here called Conversations About Weight that, again, will live as Learning Assistant in Epic. It's the idea that we could teach you some information about the trial, not that thought bubble in your head as the patient's asking you, are these medications really safe to be on long term? The data that you would take to answer that question, but not only the data to know the answer, but how do you then just tell a patient in a way that's understandable to them, that kind of validates their concerns, but also conveys that information.
Great. Thank you very much.
Thank you.
Thank you, Dr. Perreault. And one last finalist for you.
Good afternoon. My name is Devin Gilhuly. I'm a palliative care physician here at the University of Colorado, and I'm here to talk about the Complex Cancer Pain Multidisciplinary Clinic for this year's Shark Tank competition. I'd like to acknowledge my co-collaborators, Drs. Francesca Koenig and George Slichenko. To provide a little bit of background, pain is a major quality of life indicator for cancer patients and can have a significant impact on medical decision-making, adherence to treatment, and disease course. Prevalence of pain in any cancer can be as high as 55% and as high as 66% in patients with metastatic disease. Undertreated pain can lead to preventable ED visits and hospitalizations. In the last year, 272 patients at the Anschutz Cancer Center were seen in the emergency department for unmanaged pain, of which 258 were admitted for inpatient management. Further, suboptimally coordinated care between multiple clinics can overly burden patients with limited mobility who travel from far away and who have difficulty navigating a complex system. This can lead to patient disengagement and poor adherence to cancer treatment. Currently, each specialty practice that you see here has its own referral and coordination system and is staffed by professionals from diverse departments with variable expertise in malignant pain management. Oncologists do not currently have access to a coordinated system for comprehensive pain treatment. An opportunity exists at the University of Colorado to utilize the diverse and substantial expertise of our system to benefit the oncology population experiencing malignant pain and to subsequently improve those patients' experiences and adherence to treatment. This may also lead to patient retention, reduce acute care utilization, reduce opiate morbidity, and increase referrer satisfaction with supportive services. We propose a bi-weekly multidisciplinary clinic to evaluate and treat complex cancer pain with a team of specialists including palliative care, cancer rehab medicine, interventional radiology, interventional pain, and oncology counseling. We anticipate most referrals would come from our oncology colleagues. The clinic would be staffed by a lead advanced practice provider and nurse navigator who would additionally oversee the implementation of a comprehensive pain plan after the initial visit. The strategy for each case will be unique, but might include counseling, medications, interventions like nerve blocks, or devices like an intrathecal pump. As mentioned previously, undertreated pain can lead to a host of challenges, including difficulty with adherence to treatment, poor satisfaction with care, and preventable ED visits and hospitalizations. The potential impact of this program includes reducing ED visits and hospitalizations for cancer-related pain, as well as decreasing the symptom burden of patients already navigating a serious illness, potentially helping them to achieve their treatment goals. and we anticipate this program will improve trust and satisfaction with our care as an institution and as a leader in the field of cancer medicine. Our hope is to be able to launch the multidisciplinary clinic this year with support from the university and UC Health. We are still working to secure funding from members of the multidisciplinary clinical team, including the lead APP, nurse navigator, and additional provider support. We are also in need of support for help with data analytics. We are specifically hoping to identify how this clinic and intervention will impact a variety of factors, including patient satisfaction, symptom burden, and rates of ED visits and hospitalization for cancer-related pain. Thanks so much for your time, and I look forward to your questions.
Sharks?
All right, that was a great presentation. I'll start by asking about what is the buy-in that you've already established? Because clearly you need to have buy-in from UC Health on this. You said you've got some space, but you really need to be able to have their buy-in to create the clinic, utilize the Epic resources. And then also, what is the buy-in across the specialties that you want to include in this MDC?
That's a great question. Well, two parts to it. So I'll first say that the Cancer Center is on board and we're working to essentially start the clinic hopefully sometime this fall, I would imagine. We are already in the process of getting the funding. So since even I've made this video, things are moving along, which is really fortunate. So I think we have adequate buy-in from UC Health as an organization, as well as the University Cancer Center. And then to your second question about provider buy-in, we have buy-in from oncology rehab medicine, Dr. Francesca Koenig, interventional radiology, Dr. George Slachenko, myself, oncology counseling. So I think we've got most of the pieces of the puzzle, as well as anesthesia pain. There are a couple of providers who are going to be willing to support our clinic.
Great. And then you're looking for resources to get you started, but what is the long-term funding that's needed to support this program to keep it sustainable?
Yeah. So I think most of the funding, I think, is already taken care of. These are just the elements of the clinic that are underway, and we're organizing and solidifying those. I think the big ask is really support with the QI measures of this program and implementation, and hoping that we're going to be able to really show the benefits not only to patient care, but reduce costs to the system in terms of reducing hospitalizations and acute care visits.
All right, great. And then I guess if you're successful, what are your next steps, and what would you improve? I mean, how are you going to determine what success looks like and how you're going to improve upon the model?
That's a great question. There are not that many complex cancer multidisciplinary clinics nationally. So I think two things. One, leveraging the expertise that comes with winning the Shark Tank competition to show the benefits in terms of patient satisfaction, reduced symptom burden, reduced cost to the system in terms of hospitalizations, and then to build essentially to build a program that can be disseminated nationally and to publish that and get that into more university and academic centers so that we can support more patients nationally.
Great. Thank you so much. So now I'm going to ask our round of applause. I'm going to ask our sharks to swim out of here and go deliberate. And while they're deliberating, we have a presentation from last year's winner, as Dr. Runkle and Dr. Tietz talking to us about geriatrics consults in the emergency department.
Excellent. Well, thanks so much for having us. I'm Dr. Kate Runkle, and I'm a geriatrician in the seniors clinic. And this is Dr. Tietz, also in the seniors clinic.
Yes. Is this working? Great. Nice to meet you all.
So we won last year. So we're here to give you a program update from what we accomplished from winning Shark Tank last year. So I wanted to start with the oldest known vertebrate, since we're talking about geriatrics. This is the Greenland shark. So I decided to call it the Greenland grandmother. She was dated as probably being about 400 years old, so older than our country, which is pretty impressive. And so to give you some background, we presented this information last year, but generally there's about 20% of patients 75 and older that are hospitalized each year in the US. So it's a huge proportion of our hospitalized patients. And then we also know that within 6 months of an ED visit, even if they're not admitted, that older adults have an increased risk of functional decline, hospitalization, repeat ED visits, and even death. And then we also know that there's a lot of comorbidities associated with hospitalization as well. So to give you some overview on our seniors clinic patients, we have about 4,500 patients in our clinic. Back in 2022, we had almost 2,000 ED visits and about 500 admissions. The majority of the ED visits were here at our university AMC ED, and unfortunately, 84% of the admissions overall were here at our from our ED. And then 49% of the patients that were seen in the ED were Monday through Friday, 8 to 5. So all of this was data to present, to think about how we could intervene on this and make a program to make an improvement. So the intervention that we proposed last year was myself and Dr. Bolin would institute geriatrics medicine consults in the emergency room, which hadn't been done here before. Because of the data that I just presented, we decided to do consults Monday through Friday, 8 to 5 in our emergency room here. This is a flow sheet generally of what the goal was. We were only going to see seniors clinic patients because we knew that we could coordinate excellent follow-up for those patients, because I know all their PCPs and I know they're the social worker and case manager in our clinic to coordinate care. The general overview was to see those patients as an automatic consult, coordinate with the ED provider, and then coordinate follow-up after the consult. And then the project AIM that I presented last year, the goal was to reduce admissions by 10% in 1 year. We started consults in November of this year, so we have a few more months to go.
So in order to implement this, there was a bit of method to our madness, and I also drove Kate crazy by talking about change theory. And so we base this mostly off of John Cotter's leading change model, which has these 8 steps seen here. And so we thought we'd talk through kind of how we did the program by talking through these 8 steps as a framework that other people could use if they wanted to when they're implementing change.
So the first step is establishing a sense of urgency. So as I already said, hospitalization has a high risk for older adults. We know about delirium, infections, frailty, et cetera. And then unfortunately, our hospital here, as we're all familiar with, is often at capacity. So any intervention to try to reduce that was a positive.
Next, we worked on creating a guiding coalition, which meant that we met with a whole bunch of folks throughout the system. We have really good relationship with the ED leadership team, especially Dan Resnick and Greg Adams, as well as the seniors clinic leadership and seniors clinic or geriatric leadership in general.
So the next step is to develop a vision and strategy. So we had to meet with a lot of people to make this happen. That was essentially the slide prior. We had this great team, and then also meeting with everyone else that's going to be involved. We also throughout the year have done an iterative consult, trying to decide what is the most meaningful consult to do, how we can make the most impact and help the ED the most. These are just some flyers of information that we sent out about our program to many, many groups to try to advertise and get buy-in for the program.
This is just a small snippet of the different groups we met with along the way, but to kind of show how we really wanted to implement change by meeting with a whole bunch of groups. So that included seniors clinic, nurses, care managers, social work, providers, as well as the ED rehab services, palliative care social workers, pharmacists, faculty, et cetera, et cetera. So this is just kind of a small example of some of the meetings we had along the way to get buy-in and to really socialize the change.
So communicating the change vision is really important, of course. So one of the big things that we did, we added a ED consult update to our geriatrics division meetings every month. And then I also had meetings with the overall faculty in the ED. And then we also brought food, which always makes people happy. This was one of our flyers. We brought pie to the emergency department to try to play on our geriatrics inspired theme. And they could ask questions and get more information about our program.
We also really worked to enable like broader change or system level change. And so one of the big components of that was epic changes. When we first started the consult program, we didn't have this notification in place. So we worked with the data team to just get notified every time one of our seniors clinic patients was in the ED. It was a lot harder than we thought it would be and a lot longer than we thought it would be. But you see on the right-hand side of the screen is an example of a phone. And so when a patient gets in the ED, our consult providers get an alert that says the patient's here so that we're not having to automatically, like we don't have to look through the ED track board continuously, which was what we were initially doing. We also worked really hard to optimize billing, and Kate's done a lot of work with really figuring out what's like advanced care planning and other billing opportunities when we're thinking about future sustainability for the program. And then lastly, we have been working with the data analyst to really create a data set, some of which we'll share today, to understand the impact of the program and to understand if we're having an impact, I guess I would say.
So this was just kind of the general tech steps that we had to take. A program like this takes a lot more individual steps than I initially realized, but we developed the consult order. So that's its own ITSM request in Epic that took several months to get off the ground, which we got. We, of course, wrote out a consult template, which I wrote myself, and then getting that auto notification through Haiku took many, many months, and we were very grateful to get it back in December. And then our first successful Epic data poll was in January, and we're continuing to have iterations of that and validating that data.
So the last few steps of the leading change model are generating short-term wins. And so one example of that was initially every time we got a consult, we would give out some sort of geriatric candy. And so we gave out Werther's mints. We also had those little like strawberry hard candies. I don't know if you guys knew those. And then some butterscotch things, what our grandparents gave to us when we were little. And so we just wanted people to know that we were there and why we were there and have some sort of positive association. And then you also saw the like grandma's pies. We also, at a certain number of consults, put old-fashioned donuts in the break room and said thanks for working with us, but just tried to really generate wins and kind of become a part of the ED culture that way.
Sure. Yeah. So consolidating gains is one of the next steps. That's part of this, is trying to present to you the data that we have gained so far and then continuing to move forward. We're hoping to present at an ED conference later this fall and then ultimately publish some of this data. And then the last step is anchoring new approaches in the culture. So the big important part is hopefully that we become a very important part of the emergency department. They see us as reducing some of their cognitive burden when they're taking care of geriatric patients, and that we can really be helpful. The other aspect of anchoring our approach is within the seniors clinic and having it viewed as a standard of care from both our patients' perspectives and our providers. So we do a monthly update with our seniors clinic providers. Anybody's welcome to come and we sort of talk about complex cases. And then we also do a monthly review with our social worker and case manager discussing complex cases and patients that return to the ED a lot and how we can intervene there.
So this is just some initial data. So the average consult that we saw, the age was 84 years old. That's similar to our overall clinic population. And about 70% of consults were female, which is also similar to the general population of older adults. About 88% of patients spoke English, 4% Spanish, 3% Korean, and 5% other languages. And then the majority of the patients were from either Denver or Arapahoe counties, with a smaller number from Adams or other counties in the area.
So this is our initial graph to demonstrate our ED utilization. So the blue graph is all of our seniors clinic ED visits. That's all 24/7 hours of the day. And then the orange is consults that we actually saw. So obviously there's less patients that we saw because we only saw them Monday through Friday, but still a large volume of patients seen.
And then this in the next couple slides kind of shows the same outcome, but the main outcome that we're tracking is if we think that we reduced an admission. So that's when we went to see the patient, was the plan to admit the patient, and were we able to either provide additional medical information, come up with a plan so people could feel comfortable discharging them, or coordinate resources in the community. And so this is the number of times we were able to change the consult from planning to admit to discharge home instead with outpatient follow-up.
This is just a graphic representation of that. So the black, which is hard to see, are all the patients that we did not see. The blue are the patients we saw, and then the yellow are the patients that we saw and changed their discharge plan.
So about 6% of all patients where we consulted, we felt that we were able to change the disposition from being admitted to going home. This is just, we've only been doing this since November, so these are the first few months of data. But we wanted to also look at with a comparison group, not just if we felt like we made a difference, but was there any difference with the comparison group as well? And so we just recently were able to analyze some of the data there.
So this is the overall looking at patients that either did or did not get a consult, the percent of admissions that those patients had. So this is not statistically significant. You can see that p-value, but we're still early on in our data analysis, and it's nice to at least see the graph showing a lower percentage, which is great to see. It's not just us talking to the ED and saying, oh, I think we changed that admission discharge or disposition. We're actually having a numerical difference, which is awesome.
We also wanted to look to see if we changed the percentage of times that patients return to the ED. So was us consulting able to help set up other resources and decrease rates of return to the ED? It doesn't look like it. Rates are pretty similar, although I would argue that if we're sending more patients home and we have similar rates of return to the ED, that's maybe a positive metric.
So I wanted to touch on a couple of lessons learned before we get into the next steps. So this was an amazing learning process, and I'm really appreciative to all of Heather's mentorship through all of this. One of the couple highlights that I wanted to point out was we had to figure out how we could best work in the emergency department. So there's a part of the emergency department called Super Track, which is essentially supposed to be a place where patients go that need really simple workup, likely to go home. They need sutures or x-ray, and they're expected to discharge. And so working within that system to try to not slow down consults and not slow down their discharge has been really interesting, and the ED has been amazing in participating in that. So that was a growing pain that we have worked through, which has been great. General other lessons learned are Epic data changes and Epic interventions in general have been hard, but have worked through that and now know more about how to do that, but just took a longer process than expected. And then our next steps, the other aspects that we're looking at besides comparing seniors clinic patients is we have more data that we can compare this data set to try to evaluate if there's statistical significance. A big part of our program is going to be to try to evaluate financial sustainability for this program. And so we're hoping to do an ROI shortly on this program. And then a dream of mine would be to be able to do qualitative interviews of both patients and providers. The ad hoc feedback that we've gotten from both patients and providers is amazing. They're very appreciative. They think we make a huge difference, but it would be great to be able to quantify that a little bit. Similarly, with patient satisfaction score analysis, seeing if we're making any difference for patients there. I wanted to just thank everybody that's been involved. It's been a really great learning process. Dr. Tietz has been an amazing mentor, as is Heather, and the Department of Medicine letting us do this project and giving us the honor of winning Shark Tank has been really amazing to help implement this program in this hospital system. And I couldn't thank the ED enough. They've been so welcoming and really appreciative of our help and willing to work through the growing pains with us. So just really appreciate everybody's involvement in this program, and I'm excited to see where it goes next. And I think we have 5 minutes for questions from the crowd.
Yeah. Should we? Oh, you got mics. Yeah.
That's very nice work, and thank you for sharing it with us. I was wondering if going forward, you could increase the percentage of patients that avoid a discharge by being more selective, perhaps, in the patient population that you see. I mean, are there certain diagnoses that are just obviously going to require admission and others that might have a higher probability of a discharge toward home, or age groups, things like that? How could you kind of be more selective and increase the win rate, if you will?
Yeah, it's a great question. And when we talk about almost weekly, trying to figure out what is a best consult patient, it's been really tough because there are patients that have been, admitted with 2 weeks ago that had a really complex course. They wanted aggressive care. I go in, I'm assuming that they want to be readmitted, and I ask them the question and they say, no, I want to go home. I want to go home on hospice. And so I would love to say that I have a really obvious algorithm and metric to say when a consult is going to be high yield, but I haven't personally been able to evaluate that. I think in an ideal world, we'd be able to analyze that from a data perspective, not just my own personal experience. But that has been a challenge because some patients that I think are definitely going to get admitted go home, and some that maybe I thought were definitely going to go home end up getting admitted. So it's been a tough process to try to highlight the most high yield consult.
Yeah, I think one of the more predictive things is family support, and the ability of family to rally around and our ability to engage them, which is really hard to predict without talking to them. And so, yeah, it's a great question. We are thinking about that constantly. Yeah.
Congratulations on getting your program off the ground, and thank you for sharing your results. Are there other metrics that you're looking at in terms of evaluating your success? I can imagine there might be a few others, such as correct admission disposition, whether you think patient may be sicker because you know the baseline, or correct treatments earlier on as the patients are being admitted. Could these metrics provide other ways to show the ROI and the benefits to the patient care?
Yeah, I think the other metrics that we're still processing are certainly reduced stay. That's been pretty well validated in other studies that this programs similar to this usually have a reduction in admission, even if it's just a one-touch consult in the emergency room. So that is a part that we're trying to look into. We're also going to look into the length of stay in the emergency department to see if that's, statistically significant as well. And then we are also we're looking at a lot of metrics, but from a financial standpoint, those are the big ones. And so hopefully we have an overall reduction in admission length of stay. That would be huge, but we haven't looked at that yet.
That was actually my question too.
Any others?
So really interesting work, and congratulations to getting it past all of those barriers. Curious to know, like, how often testing in the ED is a barrier to patients getting discharged, and from a somewhat self-serving standpoint, it's like, how often is volume status an interest of patients in the ED?
I have to agree with your initial statement during your presentation that heart failure does create a lot of challenges for our patients, especially in geriatrics, and it is not a rare reason for people to be admitted. I have had some avoided admissions with really collaborative family, really collaborative patients and caregivers that we can figure out a way to get patients home with heart failure, but it is a really challenging one that I see a lot. So any other questions with our last 30 seconds? Okay. Well, thank you so much. Really appreciate it. Thanks for listening.
Thank you so much, Dr. Runkle and Dr. Teets. So now we're going to have our announcement of our winner in the last 5 minutes here. We're going to have Dr. Glasheen, who's our shark who is yet to speak, who's going to speak on behalf of the other school of sharks, tell us what went into their decision-making and why they chose the project that they did.
Awesome. Thank you. I must say, I am a rather old shark, and I think this is the 8th time that I've swum through this shark tank. And I mention that because I believe sincerely that this has actually been the hardest competition for us to actually pick, because all 4 of these were amazing, and we probably could have been out there for an hour debating them, but unfortunately we didn't have that amount of time. So I've got good news and bad news. The good news is that these were all amazing projects, and I think there's opportunities to potentially support all of them through some of the resources we have within the Department of Medicine. The bad news is we had to pick one, and we could only pick one. So before I tell you who it is, I just want to tell you a little bit of the rationale and the reasoning behind why we picked this group. In particular, huge problem. Number 2 is they had an excellent multidisciplinary team. Number three is Tyler showed you that value equation. And as you work your way across that numerator, this is a project that improves quality, will benefit on the safety side, reducing potential harm, will impact health equity and patient experience. And then hopefully we'll also be able to hit that denominator of cost. Additionally, we felt that it was important to recognize that this is a resident-led team. And also from Denver Health, which is an incredibly important part of the Department of Medicine. So we are very pleased to announce our winners, the Denver Health Spanish language interpreter.
All right, congratulations to Dr. Mowry and team. If you want to come up and accept the Shark Tank trophy hoisted above your heads. And just to highlight, the deliberations were exactly on that of what is a project that we feel like we can best support in a way that supports high value care across the thing. So that's ultimately what the Sharks deliberated on. However, as always, and we do this every single year, that with our finalists, that we offer support to each of you. So each of you as members of finalists, let's work together and talk about how as a department we can support you in your endeavors moving forward. So one last final round of applause for our winners. A big thank you to all of our Sharks. Thank you so much. High value here.